And so we're still talking TB because it is World Tuberculosis Day. But more frightening is the number of cases that we keep recording annually, because you think that for all the best practices that have been developed over the decades, at least we will, as a developing country, also be in a position to perhaps reach out to a lot more people who have the disease, but also vice versa, where people can have early reporting of the symptoms of the cases, so to speak. Now, let's do a thorough discussion on the subject. And Dr. Nana Konama Kote is a public health physician with the Ghana Health Service, and she is here with us. A very good morning to you.
Good morning.
If you tend to look at the narrations, for example, our colleague Matilda Pamagam was in town and tried to speak to some of the health facilities and the appropriate health physicians who were manning those facilities to get to see what really the cases were. What would you say sometimes is a misconception about the whole TB epidemic, so to speak, and why does it not seem to be going away each day?
TB seems to be increasing because we don't understand the epidemiology of TB and how it comes about. And also it's stigmatized. People have been stigmatizing TB. And so even when people think they have TB or they know they have TB, they hide it. And so will infect more people than expected. But what we want people to know is that TB is an infectious disease. Fine. But it's not a disease that is it's not virulent, I don't know how to explain it, but it's not that dangerous to infect so many people at a time. You can only get TB if you've been in contact with a TB patient, close contact for a long time.
Consistently.
Consistently. You see, that's how you can get infected with TB. Because as we sit here in this country, I can tell you about 90% of us are already infected with the TB bacteria. But you don't get the disease. You get the infection. We call it latent infection. You can have it as long as your immunity is good. You only get the disease when your immunity goes down. And so when the immunity goes down, then the bacteria start multiplying, the germs start multiplying. They multiply to a certain level, then the disease starts. That's when you start shedding the germ that causes TB. That's when you become infected. And then when people get TB, because it's an insidious illness, they start with a general feeling of ill health. We call it malaise. They start to lose weight. They have a very low-grade fever. And when I say fever, I mean an increase in the body temperature. So it's low-grade. It's not the fever like malaria that you feel you are really hot, you are sick.
You're trembling and all that.
But this is low-grade. And so you'll be living with it. And occasionally you may cough. And in fact, we've noticed that the cough is even at the tail end of the disease progression. So when people start coughing too, one problem we have is they go to pharmacy shops, go and get cough mixture, they will be taking it, go for antibiotics, some antibiotics, they feel better. Within a short time, they get the condition, the cough comes back on, off, till a certain time when they are really sick. That is when they go to hospital, even when they go to hospital sometimes. Because they don't tell the doctors how long the cough has been, because they'll just...
As history.
The history. They don't give the doctor the whole history. So the doctor will also start like a normal cough, give you something for a week or two, and then it gets better. Then if the thing comes back, they don't go back to the doctor again, they go to another hospital.
Okay. We'll talk about the treatment, but I remember early times in my journalism career, I would go to the chest clinic. That time, Dr. Jewapia was there at the time. And now you get to see that they tend to come from, some of the cases used to come from certain communities, either because there's a lot of congestion, some of them slept very close-knit, etc. Is that usually the case?
Yes. As I said, you should be in close contact for a long time. TB spreads when there's no ventilation and overcrowding. If the ventilation is good and there's no overcrowding, even if the person has TB, and your immunity is good, you are not likely to get the disease. So we get TB when the ventilation is poor ventilation, there's overcrowding, and people who have their immunity reduced, like people with HIV/AIDS, people with diabetes, people with some cancers.
Okay. So it become more like an opportunistic infection?
Yes. Yes, because when
like.
your immunity goes down. And then alcoholics and smokers. And then those who work in dusty environment like mines, yes, then they tend to get TB.
They are more prone to.
Yes.
Now let's come to the treatment, because we know, for example, in some countries, or I think in many of the developed countries, sometimes they hardly report TB.
Yes.
Why is that? And you just suppose that with why we seem to be so much inundated with a lot of cases annually.
Yes. As I said, once you breathe in our environment here, the TB bacteria is in the environment. It spreads through droplet infection. When you cough, when you sneeze, when you sing, and then when you spit. As we are talking, there's droplet coming, we have droplets coming out. So it's through droplet infection. When the person is highly infected, then you get more of the bacteria out. So the environment, is, I will not say full of TB, but we have TB in the system. So once you are an adult, even children, once you breathe, you get the infection in your system. But once the immunity is good, you don't get the disease. You have what you call latent infection. So in some environments, in America like this, they treat latent TB.
They tend to treat it.
They tend to treat it, but we don't have the capacity to do that.
Why?
We need a lot of resources to do that.
Okay,
we cannot sustain it.
Explain further.
You want to treat latent TB now, as we speak, as at the end of last year, we have about 76,000 people with TB. Do you get?
Why can't they be treated? Is it latent TB or this one is acute? The end stage?
No, but those who are showing the disease are about 44,000, getting to 45,000. But they are showing the disease. They are not showing the symptoms. But when we did the test, we did the X-rays, we did a prevalence study. That was 2013. We saw that, and that's at the end of last year. It's the same thing. And so the person doesn't know that he has TB.
And that is latent?
It's not latent. This for 44,000, it's not latent.
You have it?
Yeah.
It's just that you've not been diagnosed with it?
Yes.
Okay.
Like how a lot of people have diseases with them, they are not showing. We want people to come. We want to educate people. So that they'll be able, if they have the symptom, they'll be able to report themselves to the health facility.
That's what we're doing this day. We'll come to that point about how we want people to. Now, the thing about you look at the history of the disease, or you look at the epidemiology and all that, and you get to see that, for example, when in America they had a gold rush, a lot of people were sleeping in very unhygienic conditions. They were sleeping in congested spaces, and so we had a lot of TB at the time. But of course, they made sure that they tried to clear it out. But you are saying because they treat the latent.
Yes.
Okay. Why is it that when you go to our medical facilities, we tend to treat ailments based on the physicality? Is it because we don't have the resources to do appropriate tests and further checks?
You see,
do you get the import of my question?
Yes. When you report to a hospital, you tell the doctor your symptoms, what you feel or what you see. You tell the doctor. Based on what you tell him, we manage, we suspect common things. They tell us in the medical, common things are commonest. So you will not suspect TB when somebody complains of cough under normal circumstances. Maybe I've been coughing for a week or two. Then you say TB. No. Your first thing is to treat ordinarily bacteria, any ordinary bacterial infection. If it doesn't go, then you move for TB. But if you have a high index of suspicion, the person has lost weight, if the person is able to tell you that I have lost weight, I have night sweats, depending on the symptoms, then you will suspect TB and treat. But one thing that happens, people come and they don't tell you everything. They just tell you, maybe somebody has been ill for about 6 months. And then they come and tell you, I've been coughing, how long? Say 3 days. How on earth that a doctor, if maybe the person doesn't ask for weight loss and all those things, so does it, ask you other symptoms, other signs and symptoms pertaining to maybe an ordinary bacterial infection, because cough is not caused by TB alone. There are several things that can cause cough. Even when you sit here and somebody burns pepper, you will start coughing. So the doctor will not suspect TB because TB is stigmatized. So before you start, it's a little bit difficult. So you want to rule out other bacterial infections.
It's an interesting point you make, but this sort of treatment regime that we tend to make our patients go through, is that the same thing that is also practiced elsewhere?
Yes.
I'm talking, let's say if you take the UK, for example. Do they also try to treat you on a first-time basis and try to see how you react before they go deep into investigating?
No, yes, depending on what you tell them.
Okay.
So now we are, that's how it's done. You will not think of the bad diagnosis first. You have a few differential diagnoses. Then you treat, because you want the person to go and do some investigations. So you give some medication, like antibiotics, general antibiotics, to cover whatever you think may be causing it. And then the person will go in for the test. But what happens is, when you have TB, most likely you may have other bacterial infections, whatever. So you may feel better with the antibiotics that you have been given. But what Ghanaians do is that they don't go back. They are not, most of us will not go back. When the thing comes back, maybe go and see me in a week or two. You
Then they will never come back.
They will not come
because
back.
Maybe the cough has been suppressed. It's
been suppressed, or yes, it suppresses and then it comes up again, then they go to another hospital. I've seen a lot of cases.
Okay. Yes, now, how do we make sure that it is not only on World TB Day that we tend to make the noise and try to do a lot more community and stakeholder engagement to get a lot more Ghanaians likely to go and report cases firsthand?
You see, we've been doing community education, health workers, public health physicians, we've been doing a lot of community education. But you see, it doesn't go as far as like on radio and TV when a lot of people are watching. And getting to radio and TV too is a lot of money.
It's more expensive.
Yes, very, very expensive.
That's true.
Very, very expensive. So if you people will help us.
But we always help you. For example, this very platform is free. We're giving you this very platform.
Then you'll be coming often.
Well, if you want to come, that's
we don't mind.
Okay.
At least be giving the education for people to know. At least if you suspect yourself, you want people to suspect themselves and report. I'll give you a clear example. A gentleman was brought to me. He didn't feel that he was sick. But a relative of his who had traveled outside came back and felt that he had lost weight. Meanwhile, he wasn't fat. He was a slim guy. So those living with him thought, he was okay. There's nothing wrong. He doesn't look.
And himself, too, he thought he was okay.
He was okay. He didn't think he had lost weight. But the relatives said, no, I think you have lost weight. Not that I think. So let's go to the hospital. And I don't know, for some reason he was brought to me. I was then in a chest clinic. I said, okay, fine. If they think. So I made him run tests. Then we did a chest x-ray. And he had TB. And then I asked him to do the sputum. The sputum, the TB was scanty, But I said then he should wait and do another one. Then the following week, it was 1+. And I told him that with the scanty and 1+, I think he has TB, so we need to treat. He needed to treat. Then I treated him. In fact, when we started the treatment, I started putting on weight. After his treatment, this guy brought me so many people.
From his community?
From his community. He lives between here and Kotobabi. I don't want to mention the place.
Yeah, sure.
Between here and Kotobabi.
And those are some of the prevalent communities because they're very congested and they sleep close to each other.
So he brought so many cases. Anytime he saw somebody losing weight, or coughing, he would bring the person. And we diagnosed a lot.
Okay.
We treated a lot of people.
Now, the treatment regime that you tend to give, could it have been better if you look at the history of the treatment regimes we have in Ghana? Is it improving also?
The regime?
Yes.
Well, that is what is given everywhere.
Okay.
Now what we give.
So if you are doing the test, you still do sputum and things like that?
We do the sputum. Now we've brought in some machines. The normal microscopic work, it doesn't pick all the cases. Tests have their sensitivities and specificities. Sensitivity means how they can pick the disease if the disease is there. And now we have machines. We are bringing in machines that can pick the gene of the germ that causes TB. Now we are bringing in machines. If the disease is there, you will see it. So we have improved. I would say we have improved, and we are still improving, because now we are stocking more facilities with these machines.
We are?
Yeah, we are. We are by Ghana government is supporting, Global Fund is supporting, Dutch government is supporting. So we are getting these machines to do better diagnosis.
Do we usually record cases in only urban areas, but also a lot?
Everywhere.
Okay.
Cases come from everywhere, but the cases are more in the urban areas because of the numbers of people and even the environment.
Okay.
The environment, I mean the pollution around. So people tend to be more immunocompromised.
What environmental factors tend to cause TB?
There's a dusty environment. Okay. Dusty environment and
an infected dusty environment.
But Ghana everywhere is infected. Okay. But just some are more polluted than others. In the villages, the pollution is less. And then the oxygen concentration is higher than here because of the trees they have. I mean, they are in the forest, oxygen is more.
We have a couple of comments here we would want to run some by you. This one is from Richard Kumasi. Says, if I have latent TB infection, how can I keep how do I ensure I don't develop real TB? Or I think
keep it in check if you eat right and then you live right. Our lifestyles too, because it's a matter of just making sure your immunity is okay, immune system is good. You eat well, you don't smoke, you don't drink, not drinking, not the Budidi type of drinking, but some people really can drink, binge. They are always doing it. And
then medically it's bad.
It's bad. You become an alcoholic. An alcoholic doesn't mean somebody who
just drinks once in a while.
No, you see, we have people, some alcoholics who are always drunk. You see them, you call them like Dasram, Wabo, Bibiana Wabo. But there are some gentlemen who are alcoholics.
That means they can't keep away from the bottle.
No, they can't.
At least each day or something.
Some doctors are alcoholics.
Once in a while. Maybe
not once in a while.
Every day. In a day, he has to take in something.
Of course. And not something. They really drink.
They drink heavy.
Drink heavy.
But because they have their body is able to, they look all right.
They look all right, but your immunity goes down. Because when you drink, you don't tend to eat. It gives you some form of satisfaction, as if you are full. We call it empty calories. Alcohol. So they don't really eat well, and it reduces your immunity. And smokers, those who smoke a lot. And then when you also have HIV. So if the after the TB is there, I mean, just like you have a cork, you put it in water and your hand is on the cork in the water. As long as you remove your hand, the cork will come out. It's the immunity that puts the TB under check. So once your immunity is good, no problem.
How are you working with perhaps if it's associations, because the associations usually will comprise of a lot more people. If it's churches, perhaps welfare associations, to make sure that you spread the information about TB.
Yes, what we do is at the national level, we link up with NGOs who go into the communities to do it. We support them with funds and whatever they need, some resources, information, communication materials. And then at the regional and district level, actually the district level, that's where the work goes on. The health workers link up with churches and all those things to do that. But if there's any church at the national level, they want people to come and give them talks or whatever, we are always there. You get them resource persons to do that for them.
Now, do you have enough resources to, let's say, the various health facilities we have? Because we know that they are great in the facilities, because some facilities may be stocked with a lot more equipment and resources to be able to treat than others. And since the cases are spread, not necessarily evenly, but across the country, do we have resources in all, at least health facility, to be able to treat it?
Oh, yes.
Because we know some areas have just cheap compounds.
Yes. As for resources to treat, there's no problem. It's the capacity to treat. Some people at the CHIPS level don't have the capacity to treat.
Meaning what? They don't have the human resource?
They have the human resource, but they may not be able to do the
basic tests.
The basic tests. So what you do is, we've trained people and we are still training, because we are still having more people coming into the service. So we train you. If you suspect the TB, you can take the sputum to the lab, or you ask the person to go. You go and do the sputum, and then you do the X-ray. The sputum, we just take only 2. One on the spot, maybe an hour later or the next day you come, and then you give another one. Then when we diagnose, the treatment is now done by community members, treatment supporters. If you want anybody at all that you choose to support you for your treatment, the person will do that for you. So you give the drugs to you. The treatment supporter will ensure that you take your drugs. So we have what you call directly observed therapy. We call it DOTS. Directly observed therapy. The person will observe you taking your drugs. And we are doing that to ensure that people comply to treatment. They adhere, not comply, they adhere to treatment.
And do you get some results, positive results?
Yes. Because you know, TB, the treatment is 6 months. And we know that even 1 week treatment, if you give to somebody, the person gets better. Maybe 3 days is better, and then the next day he forgets to take the drug. And then TB, 6 months, it's not easy, you all understand. And you need to take it for the whole 6 months. You take an intensive phase of 2 months, and then a continuation phase of 4 months. So every day, somebody will come, observe you, take your drug. Then they will take till you finish the treatment. Okay.
Last year on World TB Day, it was said that in very advanced countries, the treatment period is shorter. Either because maybe they have new ways of treating, or I don't know whether there are differentials in the drug type of drugs and things like that. Is that true? Why is it that ours take about 6 months, and in some countries it's shorter?
It depends on the drugs they are using.
But do you know that some of the treatment regimes in the more developed countries are shorter?
Yes.
Why?
Because of the drugs they are using.
Why can't we have some drugs around? We can't afford.
Yes.
It's a big issue. But in communities where the infection is likely to go up, do you do more intensified engagement in terms of education and information transfer?
Yes, we are doing it. Now we want by year 2035 to end TB.
Are you serious? That's our
yes,
objective?
we want to eliminate it. By elimination,
that not too far?
2030, 35, too far.
That's too far.
Oh. No, it's not too far. Because if you look at the way TB is, even this one, we think it's ambitious. It's an over-ambitious something, but we are trying to get there. Because we want to get, by elimination, we want to get at least 1 per 100,000 population. 1 TB case per 100,000 population. So we are educated, because now we have a lot of cases in the system. We have a lot of cases. Because we are doing passive case finding, that's we are sitting in our facilities
waiting,
expecting people to report.
So now you're doing random tests.
We are
screening.
We want to. The screening is a little bit expensive. You know, going out, human resource, all the other things you have to do. But now we want to educate people. We want people to report to facilities that I think I'm getting TB. Okay. So I want it tested, and this is free. If you walk in, it's free. So we want people to report, self-report.
All right. It's a privilege having you in the studio, and we hope that next time we'll call on you, try to do the same as well. But it's just a focused discussion on World TB Day, and appropriately we're told that because it's more of an opportunistic infection for a lot more people who tend to have HIV, etc. We're getting a lot more of the cases being reported, but more prevalent are the latent ones. And so how do we make sure that we conscientize the citizenry, but also we get ourselves educated, get to know some of the symptoms, etc. So we just have to do a lot more listening, a lot more reading, and get ourselves more informed about what tends to cause TB as well. We've had in the studio Nana Konoma Kote, and she is a public health physician, and thanks for passing through with the Ghana Health Service. We hope to have you again sometime. We're taking a break. When we come back, we'll be doing a lot more discussions on AM Talk, but before then we'll have a drive-by, and we know Harvest Praise for this very Easter. They're having an event, and we all want to be there. I hope that Dr. Konoma Kote will be available. We'll give her a ticket and see whether she can pass through Harvest Praise event for the Easter.
Thank you very much.
All right, we're taking a break. We'll be right back.